Thank you for the opportunity to talk with you today. I must admit I have this awful habit of, I think I'll just put up, find sort of 30, 40 PowerPoints, and I always end up with sort of twice as many as I'm supposed to. So I do a bit of a race through, but hopefully you'll pick up some useful insights on the way. I was really happy to sort of be talking about the first 1,000 days, and it's really, since I came to Adelaide 11 years ago now to take up to start a new health economics and social policy research group. And as an economist, I think a lot of people don't really know what economists do, but economics is actually about enhancing the well-being of society using available resources. So it's sort of very apt to the question of how do we actually improve life chances of our vulnerable population with the resources we have available. So what I'm going to do is, and we've actually already had probably quite a bit about the relationship between poor health and disadvantage, but I'll start off perhaps just sort of rejigging or going through some of that material very quickly, and then thinking about a lot of my work. I think if we don't actually understand the causal pathways, and Brian really touched on that before, we'll have the wrong solutions. So we really need to understand how do people get into positions of profound disadvantage and why do they get stuck there. And so quite a bit of my talk is going to come out of that. And as I said, that really highlights the role for family, and it comes out of this sort of intergenerational transmission idea of disadvantage, which really highlights the role of the first 1,000 days. And I think when we think first 1,000 days, it's not just infant, it's also parent and soon-to-be parents, and they need to be part of the picture. And then, of course, obviously, what does this mean when we understand the sort of causal pathways, when we understand why people get entrapped? What does that mean in terms of our service systems? And I think you'll find that overall, where our resources are currently going doesn't match very closely to where they need to be. So there's a lot of people who've been working with me over the last 10 years around this work, and I think part of the message is we need to be approaching this space with an interdisciplinary framework, and I suppose my team to some extent reflects that. Particularly, some people here will know Jackie Amos, a senior child psychiatrist, and she's been quite influential in my thinking around this space. We've sort of worked together for about the last 7 years as she completed her PhD, understanding why do mothers maltreat their children and why do then children often repeat that process, even despite the best intentions of both. And there's also been important sort of academic colleagues as well as SA Health involved in this work that we've been doing. So if we look at, I'm sure people here are quite familiar with the social atlas that the Public Health Information Development Unit have put together. It's actually a fabulous interactive resource where you can go to quite fine level and identify across probably 100 different sort of descriptors, even more, I can't remember how many data items there are, and then you can actually map those on an LGA or even smaller area and just have a look at what are the risks in each locality, taking up Brian's point about if you understand the risks in a locality, that's a good start for working out what to do. So this is, and it's a bit hard to see the colours in that, but sort of median age at death. So we can look at it goes from sort of the lowest is under 50. The highest we're looking at is nearly 70. So this is 50% of people dying before and after nearly 90. So 50% of people in these localities that are dying before and after this age. And I think what's important with this is the sort of the distribution in disadvantage is huge. We're now in a situation where Australian society is one of the more unequal in the world. It used to be a lot better, and this is sort of actually a really disturbing situation, which we I think need to work very hard to address. So this is, as I said, you can go in and do it as an interactive map, look at a whole range of data. Things like percent of children under 15 in jobless families, and again from sort of less than 5% to what have we got here over 50%. So the sort of variation across community is huge. Australian Early Development Census, John's already reported some of those results. Similarly, infant deaths and low birth weight babies, huge variability across the country. And another one, this is youth, I suppose, older adolescent and youth deaths. This has actually got confidence limits on those. What this is, the mean across Australia is set at 100, so we're looking at anything below 100 is actually better than the mean across Australia. Anything above that is worse. And again, we're seeing these sort of horrendous sort of distributions. This is sort of similar if we just take, say, the Aboriginal population. This is looking at deaths by Indigenous status by age. So you can see with the non-Indigenous population, the vast majority of people are dying over 75. In Indigenous population, we're really looking at from between 35 and 70 is a sort of big bulk of where deaths are happening. So we've actually got a long, long way to go to turn things around. And this is just looking at mortality rates in children under 5, with again a sort of a reducing pattern over the last sort of 30 years. But we've still got a large gap between our sort of Indigenous and non-Indigenous children. This is sort of work we've done looking at the longitudinal study of Australian children. So this is a survey, 10,000 children across Australia. They've enrolled children, sort of infants, and followed them right through to age 16 or a bit under 15, 16. And there's a whole range of questions there about social circumstances, sort of parental situation, family situation. And we've identified at each age group there's something around about sort of 20 or so potential risk factors. And what we've done is sort of categorise children by the number of risk factors that they've experienced in the last 12 months or the number of adversities. And sort of what's clear when we look at Australian children, we've got at every age group something between, say, 8 and 20% have experienced no or one risk factor in the last 12 months, and between sort of 9 and 20% with sort of more than 5 risk factors. And the sort of life chances of those children is going to be just hugely different. A child who has everything sort of going for them in the family and community environment is going to have far less struggles going forward. If we look at the situation with Aboriginal children, there's a similar survey called the Longitudinal Study of Indigenous Children. We can find, not surprisingly, there's more children who are doing worse. We've actually got the top level here, 6+ risk factors, not 5. And we're finding by the time a child's 6 or 7, over 40% have got sort of 6 or more of these really quite awful adversities. So they're parental separation, parental mental illness, homelessness, major financial hardship, other deaths in family, people involved in crime. So they're not sort of minor issues we're talking about here. And we've really only got, mostly 1 or 2% at most who've had sort of either none or one of these things going on for them. Similarly, one of my PhD students was looking at children of prisoners, using Western Australian linked data, and I have to say we were shocked when we found that nearly 1 in 5 Aboriginal children will have a mother who's incarcerated at some point during their childhood. For these children, they have a much, much bigger involvement in the child protection system, and also much more likely to be in out-of-home care. And also the infant mortality rate is high for these. If a woman's pregnant in prison, then we're looking at higher infant mortality rates. So I suppose part of what we're saying is we actually know where to find vulnerable people. They are sort of banging up against the system wherever you look, and they're in the data set. So we actually know where to find people. So we're pretty good at the case finding. We're not so good at the helping. And I think you people are sort of some of the front line in doing that, but we clearly need to be doing better. This work is published, but it does mean that for both your Aboriginal and non-Aboriginal children, having a mother involved in the sort of who's been incarcerated, the risks to them are huge. Again, this is sort of some of the work we've done in Alice Springs. This is a cohort we've been evaluating their Nurse Family Partnership Program. It's called their FPP Family Partnership Program, where they have nurse visitors who visit. Basically, it's available to all Aboriginal women who fall pregnant, and they have access to a nurse visitor and an Aboriginal community worker from usually about 4 or 5 months pregnant through till the child's age 2. Something like 40% of people stay on the program till the child's 2. But just even some basic sort of baseline data. We're looking at a high percentage of these women who are subject to violence. There's also other data we've collected there. High percentage have really insecure housing situations. So, for instance, only 15% of these women who are pregnant are actually just living with their partner. Most of them are living with assorted adults, sometimes mothers, sometimes not. And one of the things that the home visitors say is that they can provide all the information and advice and support, but if a mother has no control over her income, no control over whether a child's got somewhere safe to sleep, they can't control people coming and going in the house, whether there's going to be food there when they come home, it's extraordinarily difficult for them to actually implement the knowledge they're gaining. So I think it's sort of really part of what we've been doing with this work is trying to get a handle of the sort of complexity and the vulnerability and the level of disadvantage we're talking about. And I think for a lot of people who are setting policies really don't comprehend the extent of complexity in people's lives. This is another program we're looking at in Alice Springs, their intensive family support service. These are families where there's been a substantiated case of neglect, but children are still living with families. They're trying to keep them out of care. And this is sort of the number of serious child protection concerns. So often people think, oh, neglect, no big deal, but usually there's domestic violence and drug and alcohol issues. And so there's a whole lot of things, medical neglect, a whole range of different sorts of neglect. So with these children, something like 68%, there were more than 5+ serious child protection concerns. And these are actually children who are still with their families. The other thing that we're looking at, so that's really a sort of description of the level of adversity and complexity and how it's distributed across the state or between different populations, is the relationship between adversity and trauma. And part of really, and Brian touched on it, is the evidence over the last few decades has been growing that adversity doesn't come from nowhere. It's sort of linked to trauma. Just sort of simply, this is just stuff from published from AHW. If we just look at prevalence of mental disorders, so family composition, so in sort of original family, this is so 10% of children in original family setting will have mental illness, compared with sort of double that in different family arrangements. And if we go through things like family functioning, where there's poor family functioning, you're much more likely to have mental illness. Employment also is another big predictor. This is some work that we did looking from the longitudinal study of Australian children that I mentioned before. It's a bit messy to read, but if we look, there's a survey that's part of that large sort of questionnaire called the Strengths and Difficulties Questionnaire, and you can use that to identify if a child at different ages. So we've got here looking at children aged 2 to 3 in the top sort of section, age 8 to 9, and then age 12 to 13. So the first lot of blocks is where they have no sign of psychological distress, and the sort of right-hand set of blocks is where they've got evidence of high level of extreme distress. And what we've also done is look at the number of concurrent adversities that these children are facing. So if we look at, say, age 8 to 9 on the right, so that's suggesting that children who are experiencing very high extreme distress, that only 2.4% of those had 0 or 1 adversities going on in their life. 76% had 4 or more adversities going on in their life. So it's just sort of highlighting that extreme distress is almost always sort of psychological distress, mental illness is almost always associated with high levels of adversity. And if we look at the children with no psychological distress, or where they're doing mentally fine, then they're much more likely to have sort of 0, 1 or perhaps even 2 adversities in their life. We use that sort of concept to do some work where we're partnering with SA Health, which Prue was sort of part of our steering group, and thinking about what we need, or thinking about how do we understand, how do we find, how do we identify infants, children, adolescents who are struggling in terms of not necessarily mental illness, but certainly psychological distress, behavioural disorders, who are struggling in all sorts of ways. And what we sort of had the idea is it's not just about the psychological distress, we need to think about the adversities they're facing. And we found there's actually a large group who have this combination of high levels of psychological distress and adversity happening. And we said, look, all of those groups need to have access to high-level, highly skilled mental health expertise, but it needs to be linked with really comprehensive family support services. That either way, there's no point having one without the other, because we actually need to be able to address all the things that are going on with this person. If you have a young teenager who's self-harming, but you don't actually look at what's going on in the household, you're not necessarily going to be able to help that person. So, as we're sort of saying, this is sort of taking us to conceptualisation of the problem, and as sort of Brian touched on, we know more and more that trauma is toxic for the brain. And the other thing and I'll sort of talk a bit more about, is that it's also, from the work that we're doing, Jackie and I've been doing, is that it also affects the relationship patterning, and I'll talk a bit about that later. But because it's toxic to the brain, and the brain is involved in everything we do in terms of our behaviours and actions and thought processes, then it actually affects all aspects of the developing child and their life trajectory. So there's a whole range of traumas that can affect brain development, from deep poverty and the stresses associated with that. Parental separation is identified as a trauma. Parental mental illness, child removal for parents and for the child. So there's a range of things that contribute and are all part of that sort of trauma story. As I said, this is sort of some of the work that Jackie and I have been writing. Shonkoff in the States, a paediatrician, has written a number of pieces in this space and has been really pushing the view that paediatricians need to understand a lot more about trauma in their work as well. So what does trauma do? And especially relational trauma, and relational trauma is also another way of thinking about child maltreatment. Effectively, it disturbs the relationship between parent and child. So it affects impulse control, cognitive functioning, ability to focus and plan, compassion. Often people go into a space of seeing people as object rather than subject. Dominant, submissive, hierarchical way of being in the world, hypervigilance, poorly developed sense of self and lack of agency, shame-based and easily triggered. And what's quite interesting when you think about those sorts of effects, it's then very difficult, and we do a lot of blaming. If you think of sort of the domestic violence sort of dialogue, it's about, just say no to anger or just say no to violence, and it's actually ignoring why someone is in that place in the first place. And it's a bit, if people's brains are damaged, then that actually reduces their capacity to have that level of control. So I think this is really critical because this then feeds into the sorts of services that are actually needed on the ground to really help people. And the other thing about adversity and harms is that basically harms tend to accumulate and adversity tends to accumulate. So if we, even in utero, in fact even preconception, there's sort of quite a bit to suggest that stress preconception can already affect the sort of the baby, and there's a bit of sort of trauma can pass through. So abuse and neglect, parental mental illness, substance use, etc. in the household, that has negative consequences for the child in terms of cognitive, emotional, behavioural, sort of often antisocial behaviours, and this then affects their often performance at school, their engagement at school. Often they end up getting bullied or being bullies themselves. Often they then go to self-medication with drugs and alcohols, often from quite early, which further disturbs brain development. So you end up with this sort of cascading of adversity and issues, and that's why you have some people that seem to accumulate adversity, further reducing their life chance, which is another reason why we need to try to get in early before we've had that opportunity for adversities to cascade and accumulate. And why is sort of relational trauma so toxic? So this is the sort of child abuse and neglect. Partly it's happening very early in life, and as I said, often pretty much certainly from in utero, and we know by the time the child's born, I mean, it's already 9 months from conception. You know, they're not in some sort of soundproof box. I mean, they're actually getting sort of hormones from the mother. It's at some point they can sort of get the sense of stress or violence or noise that's going on in the household. The brain is developing early. Relationship patterning is happening. What I mean by that, and some of the work that we've done, identified that for, or really postulated, that for children in a maltreating family setting, what happens is that, and drawing on evolutionary theory and animal models, that essentially what you have is something like an animal troop where there's threat from within. So if you think of sort of a chimpanzee troop where you have the sort of superior animal, everybody else in that troop is referential and very hypervigilant around that superior animal. You get very narrow focused of attention, and it's very difficult for anybody in that situation to have sense of agency and self, because their whole sense of being is tied up with the superior animal. And essentially we're sort of arguing that this model actually applies in families where you have child abuse and neglect, that you get these very enmeshed relationship between often mother and child, parent and child. And so that sort of relationship, that way of understanding what relationship looks like, which is very hypervigilant, very threat-based, becomes the sort of their understanding of relationships. So even when somebody moves outside of that and in other contexts, they're often looking for that threat, so they get quite easily triggered, can become quite defensive. Somebody doesn't even realise they've triggered somebody, because that's sort of the frame, that's the way they understand relationship. So I think these things are quite durable, and unless we understand that, it's very easy for people to get triggered and things to sort of go into meltdown. So as I said, sense of self with individual and agency is developing, and that can be really compromised. These insults are typically outside of conscious memory and verbal processing. So again, as against, say, PTSD, your standard approach, for more people actually understand what they've been through, and part of it's about helping to recollect. It's much more difficult with early infant trauma. And it's a sort of an ultimate betrayal from those one is expecting nurturance from. And as I said, it can be easily re-triggered from any future trauma, and sets in trained patterns that will influence one's own parenting behaviour. So we just sort of recently had a sort of small article in Australian Midwifery News thinking about this sort of whole concept of intergenerational transmission of trauma, and why pregnancy and that sort of neonate period is both a time of great risk, but it's also a time of great opportunity. And I think we need to sort of look at as a time of great opportunity to turn things around. And why is it so problematic? And as we said, that exposure to this sort of early childhood trauma when the brain is developing, it affects everything about that child, including the way they're likely to parent. So we're sort of getting this sort of intergenerational thing likely to set in for parents with a child maltreatment history, that they're very vulnerable when they have a child because that child can actually trigger their own trauma. So often that will disrupt their parenting. So again, it's a time when the parent with that sort of history is vulnerable. They need support so that they then don't replicate their own history with their child, obviously unintentionally. That idea I was just talking about before, that if a parent sets up this sort of child maltreatment relationship, then the child ends up with this sort of relational patterning, which is called agonic mode, which, while it's protective in that situation, is often very unhelpful when they're sort of, basically trying to operate in the wide world. And as I said, the sort of epigenetic pathway. So there's so many reasons why that perinatal period and infancy is absolutely critical. So I think we've already gone through that. And the other thing about, I suppose, what's also setting up the sort of intergenerational transmission pathway is that the very outcomes of child maltreatment for the child are exactly the same risks as a parent to become a sort of an unintentionally maltreating parent. So the sort of consequence, we end up in this sort of consequence sort of adversity risk cycle which keeps it going. And going back to the point I think in John's work that he mentioned that people with their own child maltreatment history are much more likely, or the children in the child protection system are likely to have had parents with their own child maltreatment history. I mean, why this is so important is that if we're thinking prevention, and often the government sort of rabbits on about the need for prevention, is if in fact the pathway is intergenerational, is from highly vulnerable who then have children who will also be highly vulnerable, then it suggests your prevention is disrupting the intergenerational pathway. It's not working with people who are doing fine, who have no adversity, and stopping them sort of becoming stopping them from experiencing multiple disadvantage. It tends not to work that way. It tends to work much more across this sort of intergenerational pathway. So it has a really important implication for intervening, which is very much about helping families to get off this sort of treadmill they're on. So this is sort of where I'm going now. So the sort of issues, the things that come out of it are firstly that the infant child must be the centre of any solution, and that actually means family. The infant child doesn't come on their own, they come with families, and we need to work with families. And the other thing is, we also need to be working with, with future parents. So teenagers are really important. I mean, particularly in these vulnerable communities, they'll be parents very young. And I think the other thing is often we sort of leave dads out the picture, and we need to work out how to bring dads in as well. And particularly often boys that sort of suffer in terms of both sort of a maltreating history, but then often they don't have, say, role models or other things like the early childhood space. There's only 3% of early childhood workers are male. Primary school, we've now got fewer and fewer males. So I think we're sort of not doing very well with our boys, and we need to think of what we can do to really help them. The other thing is that often, this is sort of a figure which is again saying that we've got the child who's either going to fall down into a sort of entrapping cycle with lots of negative things happening, or we can try to push that child up into a sort of a positive cycle where basically they end up in a situation where the sort of positive outcomes then attract further positive outcomes. Or else we can work around the edge with sort of social and economic policies, but really unless we work directly with the child, we're not going to get the best outcomes. So the first thing is the child. The second thing is we need to focus on highest risk and most vulnerable. All the work I've done as an economist and looking at a whole range of interventions is particularly around this adversity space is putting in resources to the most vulnerable that will actually give us the best returns, both because you've got a huge capacity for improvement because the outcomes without support tend to be very poor. The improvement is likely to be quite soon because we're looking at, with the sort of compounding adversity, if we can move in and stop that compounding of adversity, or even things like if we work with families with a child who's already in care with reunification, I mean, the cost impacts are tomorrow. I mean, we can be getting payoffs very, very soon if we work with the most vulnerable. And as I said, really it's the only way to prevent or to disrupt the intergenerational transmission process. The other thing, whatever we do, because we're dealing with traumatised people who are easily triggered and traumatised and already coming from a very shame-based space, then the challenge is to provide services which are highly compassion-based in a warm and welcoming environment. And I think that's absolutely not what a lot of services do. I think if anybody tries to sort of get themselves onto Centrelink, they'll find it a hugely disturbing exercise, let alone for someone who's sort of perhaps intellectually compromised. And it's not a very welcoming and supportive space. So I think we need welcoming environments, outreach-based, responsive. We need to be actually go out and find people, help bring them in to our service network. Adequately resourced with secure funding, and this is a space that you people in the room will know that funding agreements are usually 1, 2, 3 years if you're lucky, going out to competitive tender, not necessarily any logic why projects might be wound up, moved to someone else. I mean, this isn't a way to service our most vulnerable families with highly skilled expertise. So we need security, and we need actually adequate funding. And the other thing is we need to sort of go for a trauma-informed approach across the entire human services sector, because we know vulnerable people are bumping up against the sector every day, and it only takes 1 or 2 agencies who operate in a very judging and shaming way for people to be triggered to really sort of lose it, and, you know, the children will suffer with all this. And also for the services themselves, they need to be able to operate in a very compassionate and supportive way with their own staff. If the staff are supported, then they're more likely to be able to support families. And also families can see there is another way of behaving. There is this sort of compassion. If workers can themselves be compassionate to each other, then that modelling is really critical. And the other thing is to try to find ways to support self-other differentiation, to support agency, and not just sort of in a sense assume it's there. Because often people will take a lot to help them take that level of control and feel confident and competent in that. So the other thing is we need to look at something that's sort of early in life, including, as I said, sort of preconceptions. So what are we doing with teenagers? What are we doing with young mums? I know things like sort of programs here for young mums. You've got waiting lists. Why on earth would we have waiting lists for programs for, say, mums with mental health issues, drug and alcohol issues? They should absolutely, as of right, get access to the programs. In fact, I should put up there, I mean, access to best practice care. You know, for some reason, mental health, it's assumed that we don't need to ensure everyone has access to best practice care. We wouldn't take that as acceptable. If people are in you know, renal failure, yes, they have to get the services. You know, cardiac, yes, patients get what they need, but somehow or other mental health, we decide that's not important. So we need to be looking at going early, I think early childhood centres, because they're both a welcoming space to provide opportunity early in life, and also where families can perhaps be engaged with over a period of years, so because often it takes time to build up trust with people. And I think there's a lot more we can be doing in community settings. So, and the other thing in terms of, I suppose, is sort of from silos to symphonies, we're going to have to work in an interdisciplinary and cross-portfolio approach, because the families who are coming to us, they have problems which actually cross portfolios. So it's absolutely pointless coming to them with a single agency solution or single, because actually it'll fail. because people need to support it across a whole range of things to sort of, in a sense, leapfrog them up to the next level. So we need to be able to, at the same time, address their mental health, physical health, things like housing, income, education, employment. And I know that's a hard ask, but we're going to have to find a way to do that if we're going to really be able to address the sort of level of disadvantage and vulnerability we see. Where are we now allocating resources? Well, we're putting a lot of money into universal services, things like income support, tax incentives, child protection. So we're it's not really very sensible what we're doing. There's very little going to infant, child and family community mental health or family support. This is a few years old, but it won't have changed a lot. So this is actually looking at mental health payments. That big yellow block is disability support pensions. So, hey, that's where most of our money's going. The little red wedge is Headspace. Beyond blue, the little purple wedge. So we're sort of doing very little, which is actually trying to help people before they get to the sort of disability space. If we look at state payments, CAMS is that small red wedge. If we think about inpatient psych is sort of grey, corrections is the sort of deep brown colour. So again, you know, what are we doing with our resources? We're spending it anyway, but it's not really helping families. Some work that I referred to before, looking at mental health needs of infants, children and adolescents. We found that essentially the service is probably running at about 20% in terms of resourcing that it needs to be to meet the needs of infants, children, adolescents and families. And that's both in terms of sort of staffing as well as budget. And also we need a new model which is much more outreach based, but it's very difficult to do that without the resourcing available. I think I've sort of already covered that. And I think sort of the NGO sector, I think one of the challenges there is how do we get the mental health expertise in together with the sort of the social work and other family support services, because that's not necessarily available through referrals. It's sort of an interesting example. Single fund holding's been on the sort of map for decades. Certainly economists have been talking about it for certainly since the 70s and probably before. And there have been, you know, some important steps in terms of needs-adjusted funding and trying to get resources going to areas where they're needed. But we really need to go a lot further. A sort of interesting example is in the, say, Aboriginal community-controlled sector. So this is an example of the sort of programs that Congress, which is Central Australian Aboriginal Health Service. So they're providing both sort of primary care, but also a range of early childhood sort of education, infant visiting, family support services. And the advantage there is that, so for instance, with their family home visiting program, they're seeing almost all the Aboriginal women in Alice Springs. If they know someone is pregnant, then they can immediately refer them into their infant home visiting program without having relying on referrals from outside their service. We've just been doing some evaluation of that. I mean, this is just an example. One of the things the infant visitors are trying to do, one of the aims of the program is to delay next pregnancy, because we know children will have a better chance if there's a longer period between a first and second pregnancy. I mean, that graph's not the easiest to read, but the red is the women who've been on the FPP program, and the blue is those who didn't. And basically it's shifting out by about 6 months the time to the next pregnancy, which is an advantage. Similarly, we looked at things like anemia rates in children, and the FPP group is the blue in this one actually. And again, the anemia rates are somewhat lower in the children in the FPP group. That's one of the things they're trying to do, and that's important for brain development. So that's one of the issue with these children often is their nutritional status. And in fact, they give these children injections because they can't actually rely on using nutrition to bring up their anemia status. We've also looked at child protection outcomes, and for young mothers, they're getting a significant reduction in child protection system involvement through the program, which is so for the mothers aged less than or equal to 20, a reduction in reports, investigations, substantiations, and I haven't got up there, but also out-of-home care, and similarly for the first child. So this is sort of really when you work in a much more in an agency which has a much more cross-portfolio approach. I won't go into that. Some other outcomes that they've achieved. But it's difficult, as I said, we've been talking for decades about single fund holding. There's a lot of vested interest. So what happens with single fund holding? Basically, the sort of the power over the resources and how it's spent effectively goes to, say, a community-controlled organisation. It goes away from individual agencies or individual providers. So there's a loss of power for some groups, so they find it pretty hard. You've got to then get Commonwealth State, ideally, to pool money. They're not really good at doing those sorts of things. There's technical challenges in setting priorities. And there's sort of a range of technical questions, but nonetheless, there have been examples where it's worked, and often, an obvious example is, say, transport accident insurer, because they actually cover both the accidents as well as, they have the full cost responsibility. So actually, they had an interest in investing in prevention because actually they achieved the benefit of that. So what else should we be doing? I think I've gone through those principles before. I think there's some really interesting options is preschool justice reinvestment, and I think there's been some comment about what can be done in terms of the youth justice area. I think that's certainly in the States there's been some very good programs. The Washington State Institute of Public Policy have published quite a lot around what can be done, and I think Washington's been very successful in reducing their incarceration rates. And we could actually be using prisons as a place of rehabilitation and therapeutic support. And there's a range of others. I'll just show you a picture here. This is actually a prison. This is in Perth. This is the Baronia facility there for women, set up as a therapeutic facility where children can live in with their mothers. We're in the process of doing an evaluation of this, so children can actually live in till they're 6 and then have weekend visits. There's a lot of interface with the community. They take the child out to childcare, really work hard with the women around their parenting skills, around providing them with training so that when they leave they can get a job. Very, very different sort of model. I think we could be looking at investing, as I said. I think we need to be doing far more in mental health, and particularly infant, child, adolescent. And I think we need a new model which has much more outreach. We need to be looking at training, and we're having a conversation of how do we train the skilled workers in this space working with these families. It's not easy. They're very complex. And when we're talking about damage to brain, I mean, brains can be repaired, but we can't expect that to be a simple and easy process. But the point is, if we don't invest in this, we keep getting these really sort of tragic outcomes. They're both tragic for families, tragic for society, and they're very costly. Universal services do have a role in case finding, but at the moment we seem to be putting a lot of resources into case finding and not enough into actually then helping families. As John sort of showed in his slide, there's a lot of children that are screened out and who get no support, and even the ones who screened in get little. So what are the barriers? Some of the barriers to sort of moving forward as service provider reticence to work with the most vulnerable families. Often, in fact, they get penalised. The way systems work with sort of KPIs, if you take on the more vulnerable families, it's not so easy to get the results that you're looking for. Clinician reticence. Often, if you look at things like the Better Access program, joke, that basically when you look at the distribution of psychology services, they're all in the more advantaged suburbs, not in the less advantaged. Psychologists, they don't want to take on patients, the more vulnerable, and they get rewarded that way. So we have a system that effectively rewards people for taking on the less vulnerable. So And the other barriers are things like evidence-based. We still need to build more evidence there, and it's not simple. There's major organisational barriers. We still, I think, have punitive community attitudes. You can see that in the domestic violence debate. We can see that in the debate, GOM 18 orders, children are removed from perhaps 12 months. It's very difficult for those families to get their children back. People are constructed as, whether it's domestic violence or child maltreatment is bad, not troubled, not traumatised, not challenged, not sick. And I think we need to change that conversation because I think until we actually change that conversation, we're never going to get the resources into this space. And we've got sort of power and vested interest that somehow or other manage to sell their message as well, we're talking for the community. It's like, no. And I think also in this space, how do we, even though we've got a whole aim is to engage with end user, how do we engage with infants? How do we ensure that they're actually being adequately represented? Who is talking for them? As an economist, I think there's sort of role for economics in this space to generate the policy relevant evidence, to do more work around costs, return on investment, cost effectiveness, cost consequences, and there's a lot more we could be doing, but there's very few economists working in this space, unfortunately. And I think everybody needs to be, I suppose, jumping up and down about the need for equity, that it's an absolute disgrace, the inequity we have across every outcome measure we can think of. For those who are in the research community, we need to make sure we're doing good quality science. And in terms of the dialogue about prevention, let's shift that to preventing intergenerational transmission, not preventing low risk going to high risk, because the intergenerational is the main transmission pathway, not the low to high risk, which means really let's put the resources with the most vulnerable. And ensure, as I said, as an economist, I need to be ensuring that the economic consequences of not taking the efficient path is made clear. And that's where I'll finish. Thank you.